I invite the second speaker, Dr. Ashok Kumar, to talk on abdominal cocoon. And it's nice to share because he's my teacher at SUPGI. And in continuation of the previous thing, the abdominal cocoon is again a challenge because if you explore, then you might have a problem of intracutaneous fistula. So all to you, Dr. Ashok.
Thank you, Dr. Manisegaran, and I think most of us not encountering very frequently the cocoon of the abdomen, but in India is mainly we found the tubercular patient off and on, and we land up with technical challenges during the surgery. So this was the first terminology. If you go the historical perspective, it was used like peritonitis chronica fibrosa encapsulata, and this was for a young female patient who had a kind of pre-menopausal, and this was a kind of a fibrous collagenous membrane encapsulating the small intestine. But subsequently various nomenclature has been given, and a syndrome which has been finally accepted to be labeled as encapsulating peritoneal sclerosis was clinicals characterized by acquired or inflammatory fibrocollagenous membrane encasing the small intestine, resulting in the recurrent symptoms of bowel obstruction. So what happens? It could be continuous obstruction, it could be intermittent obstruction, or it could be repeatedly with the symptoms of intestinal obstruction. But the actual term cocoon was given by Fu et al. In 1978, maybe 100 years later, the first description of encapsulation, and you see how the small intestine has been put inside the cocoon into a cocoon, and all the intestine has been lying here leading to the obstruction. And if you operate this patient, you find a fibrous capsule encapsulating the intestine, and this is the CT image with kind of lots of bowel fluid, and this is a small bowel lying into consider pattern. So this is a classical description of the imaging, operative, and the diagrammatic representation of the cocoon of the abdomen. So there are various causes, and among the various etiology, the etiopathogen, the most one and most common in the literature is secondary to the peritoneal dialysis, and in India we see either tuberculosis and sometimes malignancy, our clinical practice, and there are several associations found is the cryptorchidism, the omental hypoplasia, peritoneal encapsulation, and mole rotation. So the most important thing, what is the pathogenesis of this? This has been studied mainly on the patient with peritoneal dialysis, and they say it's a two-hit theory. First hit is disposition by the continuous abdominal perineal dialysis, and these lead to two changes. One is the morphological changes, and second is the functional changes. And finally, what happened? There are various morphological changes takes place, and then it leads to the formation of the increased production of fibrin and reduced E-casdin, increased this TGFA beta, and what happens finally, it leads to the second hit by the repeated dialysis, or if there is a bleeding due to the peritoneal dialysis, and this subsequent to the inflammation, production of fibrin, and then fibroblast proliferation, peritoneal fibrosis, intestinal adhesions, and cocoon formation. So this is very important because at some point we can obstruct or maybe curtail the process by maybe stopping the peritoneal dialysis if it is the cause. Common presentation would be abdominal pain, abdominal distension, nausea and vomiting. And if you find a similar kind of thing in a patient who has a repeated multiple kind of episode that resolve without any treatment and have a recurrence of symptom, and more so a patient is of tuberculosis or peritoneal dialysis, you can think of this entity. So the most important after clinical, the diagnosis is very important and very difficult also preoperatively, but if you know the history and clinical examination, so it is very helpful in these patients to see the plain X-ray abdomen, and you will find distended bowel loop, peritoneal various fluid level, and sometimes you see the calcification in this patient. And the CT is the most important. However, there are other investigation, expert sonologist, barium will follow through, and MRI and CT is almost equal. If you want to choose, go for CT scan. So these are the trilinear pattern of the ultrasound, where the hyperechoic calcification wall fibrous capsule is seen, and then you will see the here the second is the dilated bowel loop, which is almost hypoechoic, and there is a fluid into the lumen that is a little bit a partial hyperechoic, that is known as trilaminar pattern, which helps for the diagnosis of the cocoon of the abdomen. And this is already I have described this, and this is the characteristic central clumping of the small intestine, and you see even if you push with the transducer, it does not slip in and there doesn't change the pattern, almost it is constant and it is diagnosed. In some of the patient we can find the fibrinous adhesions leading to fibrous band crossing the either of the dilated bowel loop or sometimes crossing the peritoneal cavity. So the another imaging is the barium study, and where you can see this U-shaped configuration of the U-shaped means does not changes with the barium or positioning of the patient, means it is fixed in position because of the cocoon covering the intestine and bowel is not able to move freely. So the CT is very important. You can see here there is a calcification, minor calcification here, and thickened bowel loop here, and encasing the all small intestine in caps with a kind of particular pattern, and this is highly diagnostic of the cocoon in a patient with tuberculous peritonitis. And this is the few other film of the CT scan. You see the axial pattern. This is the thickened bowel, and this is all the loop has been put in concertic manner. And this is the obviously the axial cut, and this is the coronal, and this is the sagittal section. And you can see the thickened bowel here, and there is a loop of intestine lying in a very well defined pattern, and there is some fluid here, and if somebody is very careful, you can see the kidney is also small in the case of patient with chronic renal failure. So how you can diagnose? One, you can suspect a patient with a cocoon of the abdomen, and then history and physical examination helps to establish the diagnosis. To confirm, CT is very important, and if it also helps if the diagnosis is confirmed, you can go for a defined treatment line. If not, then symptom is persisting, then you can go for a definitive laparotomy. So what are the CT characteristics? I have already described, but you can find thickened peritoneum, peritoneal calcification, dilated loop, bowel thickening, and lobulated ascites. These lab parameters are not much helpful, but associated one can find into hypoalbuminemia. Inflammatory markers should be raised. If there is infection, one can find leukocytosis, and obviously chronic obstruction, malnutrition can lead to anemia as well. And these are the feature on laparotomy. The diagnosis is not asserted preoperatively, and histology you can find lots of fibroblast, collagens, and the mesothelial denuation and neoangiogenesis. So in our setup, the issue is how to differentiate mainly from the tuberculosis to the peritoneal carcinomatosis. The difference is that here the matted bowel loop are seen, here the bowel will be there, but the one important is scalloping of the margin of the liver and spleen. In this situation, the bowel would be hyperattenuating, where it would be low attenuating. The rest of the things are very not commonly seen in our setup. So these are the two differentiating features, and it can be differentiated preoperatively or during the surgery. So based on these various parameters and pathogenesis, this has been staged into mainly this staging in the based on the peritoneal diuresis related to encapsulating sclerosis, and one is the increased peritoneal permeability, the first stage. One can stop here. If you want to stop, then don't go for dialysis further. Then in inflammatory stage, and these are the various symptoms and signs into the inflammatory and the permeability stage. Stage 3 is where the patient start forming the encapsulation and leading to small bowel obstruction and symptoms of the obstruction. However, when the formally cocoon is formed, fibrous layer is completely engulfed the bowel, then the patient develops ileus and a mass leading to abdominal anorexia and the symptoms. If the further it changes, the bowel may go into lead into the minor changes of necrosis and even the gangrene, and it's depending on how long the cocoonisation has taken place, with the duration also and also the etiology. And this helps how to decide on table for the therapeutic intervention. So coming to the treatment option, so if the patient has a clear-cut obstruction here, you can treat like a patient with obstruction, initial conservative management, and if does not relieve, then you can go for surgery. But if you see the stages, I have described the stages of the cocoonization. So if it is a pre-stage to inflammatory, then encapsulating, and then ileus phase, you can change initially in this stage 1 and 2, you can go for conservative management. Stage 3, you can go and treat with steroid and then also tamoxifen, which I will discuss subsequently. And if doesn't work, then you can go for total parenteral nutrition if patient can afford. If not, then you can directly go for the surgery, take the patient for surgical intervention. So what are the commonly available medical treatment and which is being practiced? One is the corticosteroid group, second is the immunosuppressant, and third is the hormonal antagonist. And among this group is the prednisolone is the commonest in the steroid group, azathioprine being used in the immunosuppression group, and tamoxifen, which is a hormonal antagonist which minimizes the fibrogenesis and lead to the release of the bowel. The doses for the corticosteroid prednisolone is 0.5 to 1 milligram per kg per day, and it should be initially tried for 1 month. If the patient's symptoms improve and disease resolved, then one can find as a weight gain, normalization of the protein, and disappearance of the cocoonization on CT scan. If does not respond, then you can move to the tamoxifen, and it can be given up to 1 year, but assess the treatment response after 1 to 6 months. If patient improve, then continue, otherwise you can switch on to the another group of treatment and think of operating this patient. So another medical management is azathioprine, which is less commonly used, and also is the mycophenolate is all in clinical practice. The experimental medication which are anecdotal reports are still in infancy are the mucolytic alkaloid, xanthine derivatives, anti-diabetics, anti-fibrotic, anti-inflammatory, immunomodulator, antifungal, and autologous stem cell therapy is also being tried in some group of studies. So now coming to the surgery, so this is a patient of 14-year female which was operated in 2010 and presented with the acute intestinal obstruction and did not respond to initial conservative management. So we took this patient for surgery. So this is a 2 minutes video. So the best, initially we tried to separate the adhesion, however it did not work, so syringe, a blunt end of the syringe was used to create a plane between the cocoon and the bowel, and giving a small saline so that you can keep a space, and then a seizure was used to create a plane between the bowel and the fibrinous capsule. So the best way is not to use cautery in this situation. Seizure is the best one to create a plane and do a dissection and take time, because otherwise one may make a lots of enterotomies and do more harm to the patient than the benefiting. So part of the bowel has been released. Still majority of the part of the small intestine is surrounded by this cocoon, and not only the loop of bowel or multiple loop is surrounded, but there is most of the time one may find a fibrinous thin or maybe thick adhesion between the bowel as well. So after you release the cocoon, you have to separate the bowel from one to other, a kind of analysis needs a careful and meticulous analysis, and the sharp dissection is always recommended with the seizure. And best technique, ask your assistant to use two hands to lift the two ends of the bowel, and which raises the thin fibrinous adhesion, which you can create a space with the seizure, and then here one can use a cautery once a space has been created. Now, most of the adhesion has been released and cocoon has been removed. We are inspecting the entire bowel from DJ flexor to the IC junction, and sometimes if the colon is also engulfed, you have to do a colon release also. So, what are the long and short term outcome of the surgery? This is one of the largest Japanese study of 243 patients, where introlysis was done in 240 patients with other small procedures like bypass or jejunostomy or ileocolostomy, or in some patient only a diversion in the form of enterostomy in 2 patients, and no surgery was done in 3 patients. And majority, you see around more than 35% of the patient has a kind of recurrent problems and require surgery, like in 58 patient out of 243 require 75 operation in this patient. The right hand diagram shows, the black bar shows the first surgery, and the same group how much patient require the re-surgery. The re-surgery is also very significant, and complication related to the surgery was more than 50%. So, half of the patient has one or other kind of complication, and related to death related to direct in hospital or after discharge is about 1/4 of the patient. Now, coming to the last couple of slides, so this is the proposed option for prevention and management. So, the prevention is very important at this stage when patient goes from peritoneal early stage or the inflammatory process is there. You can stop it here, or maximum from stage 2 to 3, not in stage 4. So, these are the various stages. So, prevention is either in stage 1 or stage 2, and how can you do? You can do by obviously stopping the peritoneal dialysis if it's a case of peritoneal dialysis induced sclerosis, or you can give some kind of biocompatible fluid which can minimize the adhesion, and you can same time start anticipating the problem, and you can start the antifibrotic like low dose steroid or with or without combination of tamoxifen. And there are many new drugs in the pipeline under the research, and the future is very promising for the cocoonization. And finally, the last slide, I can conclude that the cocoon is a rare but serious condition that can result in encapsulation of the bowel, being thickened fibrocollagenous peritoneal membrane and recurrent episode of obstruction. The etiology is multifactorial, and the most common is the idiopathic, followed by long-term peritoneal dialysis, bacterial and peritoneal tuberculosis, malignancy, and many others. The clinical features are usually non-specific, and knowledge of the radiological feature is necessary to make a pre-operative and precise diagnosis. The treatment should be directed at the underlying condition, optimizing the nutrition, and the corticosteroid or tamoxifen alone or in combination, depending on the disease and the contraindication. In patients who have failed conservative medical therapy, surgery in the form of enterolysis should be considered. Thank you very much for your patience hearing.
Thank you, sir, for the extensive coverage of the topic. And while doing the enterolysis, how far you should go for releasing all the membrane, because some part of membrane may be very adherent to the bowel. So, what is your limit to?
The objective should be release the maximum bowel whatever you could, and if at particular places, if you are not able to release it because of any reason or fear of perforation or injury, you can leave it a bit of it, but not the long segment, and which can lead to further obstruction and narrowing. In that situation, even a small segment of bowel, if it's a larger segment, you are not able to release it, you can resect it, and the patient is fit, you can do a anastomosis, otherwise proximal diversion and distal mucous fistula.
Thank you. Are there any questions?
Post-operatively, would you put them on any medication to prevent further?
In our series, we usually, if it is a tubercular, we have started anti-tubercular treatment in almost all patients, and in patient with dialysis, I have discussed with some people, and this situation, low dose steroid, if it is not contraindication, it is given to prevent, because the patient requires recurrent dialysis. So one can switch either from peritoneal to hemodialysis, or if you want to continue the home by abdominal dialysis, then low dose steroid is adequate.
So if they were not on peritoneal dialysis and there is no histological proof of tuberculosis, what would you do?
This situation is obviously one has to rule out the mostly it is idiopathic, or it may be spontaneous bacterial peritonitis. In this situation, it's a very advisable if patient has recurrent symptom, low dose steroid, especially the first would be the the prednisolone should be given from minimum 1 month, as I have discussed. In this one of the dust trial says you should give for 1 month, and the symptoms improve and the patient does not worsen, then you will continue for 1 year. If symptom does not improve or the patient worsen, you should stop it.
See, we all know in clinical practice that even if we use all the available tests for tuberculosis, many of them would be negative, and we treat them only on the basis of that we suspect. So would you put these patients on low dose steroid and ATT also?
Not in all patients. What I have my limited experience, we will only put this patient the post-operative anticollateral in majority we clinically suspect, but not on steroid. But miliary tuberculosis, which is one of the form of which can lead to most commonly sedation, steroid is well recommended in low dose.
Thank you, sir. Thank you.